Good morning. We are too many here, right? So at least if some of you will say good morning, I can hear that, yes, we are here. So thank you very much for joining this session in the morning. And maybe on Saturday, bringing you from your homes to this conference may be a challenge, but I think the people who are very much interested, they are already here. So thank you very much, you all who are present, and we are going to start the day with the first session. And those who were here yesterday, whether online or in person, we have very good deliberations on two themes. One was smart build, that how you can build a smart hospital, and then how you can operate smartly. Under the theme is smart operate. And today we have a couple of more, as you can see, smart quality and smart business. So this session is basically on smart quality. And some of you may be aware of what is smart quality, some you may not be. So perhaps by the end of the session you would know what smart quality is all about. And this is a new term, if you say so, that how we can be smart in implementing quality tools, quality improvement activities to make our system better and more safe for our patients. So in this session, I'm your host for the day. I'm Dr. B.K. Rana. I'm the CEO of QAI, Quality and Accreditation Institute, one of the conference partner as well. As you can see the logo QAI. And I will be talking about briefly on that in my presentation. So I am the CEO, and also I am on the board of directors of International Society for Quality in Healthcare, is ISFTEH, and have been on the board of International Society for Quality in Healthcare, ISQA, and also privileged to be the expert of World Bank and Asian Development Bank and World Health Organization for setting standards and accreditation bodies globally. So thank you so much for joining, and with this introduction I would like to move on to the technical session and would like to invite slight change in our program in order of speakers, but not in the theme. So I would like to invite Dr. JAICOB VARGHESE. So Dr. VARGHESE is a senior consultant and head of the Department of Critical Care Medicine at Rajagiri Hospital, Aluva, here in Kerala. And prior to this assignment, he was senior consultant and in charge of Department of Critical Care Medicine at Narayana Hridayalaya Hospitals in Bangalore. He is an accredited teacher in critical care medicine, attached to National Board, and he is also the vice president of Indian Society of Toxicology. He has several publications in index journals, and a very smart doctor, basically. And that's why he's here, like you are smart participants. So thank you very much, Dr. VARGHESE, for joining us, and I would like to request you to please come over for your talk, please. Thank you.
Good morning, dear friends. Thank you for a smart introduction, Dr. Rana. I think everything is smart here, right? That's what that smart has been keep on repeating every day, I think. I'm extremely, sorry for the delegates who have come from outside, because you have the taste and experience of what happened yesterday in Kerala. That is what, that thing we have to be smart enough to overcome that. We will. Thank you, Dr. Rana, for a kind introduction, and Hospex team, because, I know it's the first venture. That's what I heard about it. This is really a good start. Dr. Rema, also my appreciation to all of you who is in the background to work for this relevant, conference. I think over the years, God and time will make you prove that what you initiated today will be a success in the coming years, because this is what, we need to think. The healthcare is an industry. I think I call industry, but more than an industry, it is something which you need the combination of combination of every mind, which includes technology has got a larger role, and which will definitely is going to be the in thing in the coming years. So relevance of the conference, I think I'm really, really sure that this is going to be getting bigger and bigger in the coming years. I'm just waiting for my slide to get loaded. Even though I'm a clinician, I work in an institution called as Rajagiri Hospital, which has got an engineering college attached to it. So when we started, we couple of doctors, when we start thinking about some kind of a solutions we require in our hospital. When we listen to, when we tell the problem to the engineering colleagues and the students, the brightness and the ideas which come out has amazed me a lot. So I always believe that, the technology, the combination of things will definitely make hospitals and everything smarter. And the theme which I've read over here is, how smaller hospital can enable smart care. I don't think smaller is a term which is defined by you. The care, patient care is going to be, has to be the same everywhere. Technology will definitely help. I strongly believe in that conviction. I just want to make some point. My presentation, even though it is based in a tertiary care center, I think let me make some point to substantiate my view on how do you make sure that the smaller hospitals also become smart for you to help. So my point to you is that how a remote patient monitoring can help in, how it is help in the future of future of healthcare industry. Now, my disclosures are there. This is purely based on a pilot project and my understanding about remote patient monitoring, which is done in my hospital, Rajagiri Hospital, which is very close by. All of you are welcome to come and visit. I'll be always there to help you, show around. No financial grants received, and only a few slides are self-made. As all, the company which supports me in doing the project has helped me in that. Now, what is the overview I would like to cover in the next 20 minutes is that what are the key problems you face in the healthcare industry, how to address these challenges, how we demonstrated remote patient monitoring in our own experience, and how does this address these areas, and the stasis monitor, that is a monitor which we tried, I think they must have a stall there. What is a pilot project, and how to use technology to make smarter, even bigger or smaller, or whatever the hospital you call it as. Now, for me, if you look at the people of non-medical over here, ICU is a specialty which I work, intensive care unit. People have got mixed feeling by getting into the ICU. That is an area where, it is like you will be critically sick, or you will be cut off from the family, and you will be in the ICU, you will be in the intensive care unit for whatever major complications you have got. But there is something else which, once the patients get better, then the next step is that we move them to the room. But there is a transition zone which always happens. They are getting better, but I may not be able to move them out of the ICU. And in that kind of scenario, there are hospitals has got different name, which some of you know that is called as the step-down unit or the high dependence unit. Different names it has been called. That means the transition shown between a highly monitored, highly intense unit like an intensive care unit and to the room, the floors, whatever you call it as. The intermediary area is a one area which some hospitals, almost every hospital will have a section like that. You move the patient there. Two reasons. One, they're getting better. You can utilize the ICU bed for another deserving patient. Second one, the cost also will come down. The expense is something which in our country, we need to be cost conscious always. That is what any technology we build up, that has to be kept in mind. That's what my sincere advice to all the technologists over here. Now, when you go to step-down units, it is something which is a very dicey situation. Patients are getting better. However, there can be challenge because the care, the monitoring of the nurses won't be like an ICU. You have 1:1 or 1:2 ratio. Ratio changes again. And the second point is that the knowledge gap. The lot of errors can happen in between because the nurses are not highly equipped like an ICU nurse. They have their own limitations. The number of patients will be more. So the knowledge gap handover can be an issue. The third thing is that alarms. We do have monitors there, but the monitor alarms is something which these patients are getting better, so they will be more active. So alarms, suppose if you have a heart rate alarm, when you are active, heart rate goes up, and that alarm is not a problematic alarm. So the alarm fatigue and the alarm response is going to be limited, and most of us have faced that this step-down unit or high dependency unit is an area where patient deterioration is not picked up by a nurse or a healthcare worker, so that the outcomes can be affected if not picked up early. That is a challenge all of us face. So the transition zone is good with the concept of a lot of things I have mentioned here, but it can be a dangerous place. So how can a remote patient monitoring or a smarter setup can help? That is my first challenge in that. Similarly, all of you know about another critical area is an emergency room. The patient comes there. People know that at a patient entering the ER door, the first thing they will do a triaging. they will convert the patient to 3 zones. We call it as priority 1, 2, 3, or the red, orange, and the green. Red means they are sick, they will be attended immediately. Orange means, okay, any immediate things are done, they keep the patient in the ER observation area. These patients are the one who get admitted, either to ICU or to the room. The third is a green, which is stable patient. You can see them, whenever time it comes. The problem in our country is that, in Western countries or in countries like Singapore, the ER is like difficult to get an ER if you are not very sick. ER is an area where the patient goes for sick. But in our country, our place, after 6 o'clock, everything is an emergency problem. So the number of cases, the load is high. In that problem, we can miss patients. We can, suppose you think it is an orange or a priority 2 patient. Because of the overcrowding, you keep what is called as an ER observation area. And when he goes there, either they are okay to go to the green and then get admitted, or these patients can deteriorate. And that is the area, gray area, which may not be monitored properly. Smart remote monitoring can definitely help. That is the second use case what we have tried. Again, in the ICU, one of the frequent thing what we see, I don't know how many of you work in the ICU, but the early morning when doctors comes, when the family comes, all the patients are kept neat and clean. Imagine these are all the patients who are on a ventilator, who are on multiple supports, life supportive devices, and the nurses has to do a cleaning of the patients they do it in the early morning. That is a time where lot of deterioration happens, because it is not anybody's mistake. Their attention goes slightly towards the cleaning part, and alarm, all these things may not be noticed properly. So this kind of area, if not monitored properly, because by somebody outside, that's a remote monitoring, this is a challenge in the ICU. Again, the pandemic what we have faced, number of beds are shortage, patients are increasing. Some patients need to be placed out of the ICU in an area, which again we call it as step-down ICU or a high-dependency unit, where they are not very sick to be ICU, but they need to be monitored. So pandemic situation always makes you think too much. But these patients go to an area where it is completely unmonitored, then you're going to be in trouble, because once deterioration happens, things are lost. So how can we remote monitoring help them? Third point is that I mentioned the point called as benefits of early discharge. One of the challenges we faced in our ICU patients especially is that they get into what is called as a delirium. I don't know how many of you know the term delirium. Delirium is a mental condition where your complete psychological aspects get affected and you started talking abnormal. That is not a disease. That is not a problem with the brain. That purely happens if somebody is completely cut off from your normal environment and come to a setting like ICU. So we have adopted a technology called as shift the patient early to an area, either step down ICU or the room. But again, the problem is that once you go to the room but completely not stabilized, then the deterioration monitoring again will be a challenge. And the last, which I always believe right now, is that the patients who are sick, like coming to my specialty, they want to get better in the presence of their family. So a room-based ICU, rather than in an area where every patient is sick, he is looking around and he is seeing all patients on a ventilator here, I think his mind get affected. So what if in the room, where room is being manned by a nurse, if possible, or the family sitting with the patient, and we have some monitoring devices which help us. So these are all the challenges which can be addressed by a smart system. Again, if you know what is the term called as rapid response system, it is a term which has been used in almost all the hospitals, tertiary care centers, called as RRT or MET, Medical Emergency Team. Now, the concept is that you form a team of either doctors or nurses. They will be in the hospital all throughout the time in shift. Any deterioration happens in anywhere in the hospital, you announce. Some people announce code blue, some people announce code purple, whichever way your hospital has got a policy, or because this means that as alerting the rapid response team to come to the patient. Now the problem is that who will alert that? The bedside healthcare worker, which could be a nurse always. So this alert system is sometimes, unless they are proactive in picking up things, or they escalate to the level that the PA system or the telephone is activated, you may not get the complete benefit of creating a rapid response system. So why can't we think of, okay, these patients are being monitored in an area, whichever area it is there, and if the rapid response teams carries a smartphone with them and all the messages the alarm systems, which is going to get bad, comes to their phone directly. So instead of waiting for the bedside nurse to pick up a patient getting sick or getting deteriorated, can they proactively avoid a situation from, that matrix of escalation may not work, so they come to the unit before calling. So that definitely will have a value, because we always believe, doctors believe that once that cycle of deterioration happens, unless you intervene early, the end result may not be as good. So these are all the challenges which hospitals face, in any hospital face, and how technology can help. So in short, there can be a workforce shortage of manpower. We all know that, Indian nurses have been wanted everywhere in the world. They have been, previously they used to work for 3 years in our hospital. Now within less than a year, they have been taken abroad. So workforce shortage is going to be a huge issue. It's an issue now. Knowledge gap, because the lack of coordination between the patient, the nurses or the doctors when they give handover. So because human mind can forget, they forgot to write. So that is the knowledge gap. Limited ICU beds. You have to be careful about ICU beds right now, because not everybody needs an ICU, but they need to be in a unit where you can monitor properly, where you can get things done in a proper way. And the cost is something which is rising day by day. So shift early from an intensive care unit, which is an expensive always, to an area which is less expensive and better monitored. That's another problem in the healthcare industry. We need to tackle it. And data integration. That is something which is the current in thing right now. The data is something which has got a lot of value. Correct analysis of data is going to give good results. So data integrations at the clinicians like me, in my fingertip, my phone, is going to be an excellent tool to develop, and which can definitely help. How to address these challenges? I think technology, digital solutions is something which every hospital is moving towards, whichever capacity they can. I think you will be better knowing than me, which is by using artificial intelligence, cloud computing, extended reality, and Internet of Things. I'm not a technologist to tell like that. So it is time to embrace the innovation and technology that will help hospitals and people like me to reduce the incidence of code blue. Means the cardiac arrest. Code blue is a term which we use when a patient suddenly had a cardiac arrest. That means his heart stopped beating. We need to act immediately. So to reduce crashes in the hospital and lower the staff burnout and alarm fatigue. That is an important aspect when you consider the healthcare workers' mental and physical status. ICU traffic can be improved. We can shift the patient early, utilize the bed, because shifting to an area where it is monitored completely, we are confident that I am going to get a indication that my patient is deteriorating. That is again a good concept. Empower doctors and healthcare team. It can predict the alarms. The scoring system what we use can predict patient deterioration. Altogether, it can reduce the cost of the patients from the hospital cost, and it can improve patient and family satisfaction. So how does my topic, remote patient monitoring, help? This is an example of a remote monitoring remote setup being done. And every bedside there is a monitor being kept. It goes to the cloud. From the cloud it reaches the dashboard, which is central monitor in the ICU or in separate area, or the clinician's phone. And by some data, it has been shown to reduce in the number of code events, reduction in the ICU transfers, because you can act immediately, reduction in length of stay, and of course costing can be definitely done. And as I mentioned earlier, the unplanned ICU admissions, because if you can identify a deterioration at the earliest, probably a bedside intervention can definitely avoid a transfer back to the ICU. The healthcare worker who is there with the patient is solely responsible, but it's a human person, it's a human mind over there, human health of human person over there. Limitations will be there. If technology helps that person, definitely it is going to be a boon. And what about the documentation? That is when hospitals are going towards accreditation, you are an ABH, you are JCI, the most of the time will be spent on documentation. We need documentation. It is important. However, documentation takes a lot of time. We sometimes tell our nurses, I think most of the time is spent on documentation than patient care. It is something which we are all looking into it. But if the technology can help us in getting our documentation, especially the vital parameters, integrated to the systems, it comes directly, the time is reduced substantially, and the care for the patient at the bedside is going to increase. And telemonitoring is going to help in patient care. So if the remote patient monitoring, by principle, by its all methodology, it will give a real-time updates. It will give your tabular and graphical format. And as I mentioned earlier, we follow what is called as an early warning score. The early warning score is a score based on each patient's vital, your heart rate, your blood pressure, you have an oxygen, you have a urine output coming. All these things are integrated to a scoring system which we clinicians do in the bedside. Nurses do that. And if the score system is going more than a prescribed value, they have to alert. But as I always point out, that is a human interface there, which always can go wrong with whatever reasons I have mentioned. So if technology helps us to identify, and I am as a clinician getting a beep or getting an alarm in my phone, or as I mentioned about the rapid response team, the RRT, which is always there in the hospital, he has got a smartphone and compromise patients who was in the room, because not every patient is as stable as in the hospital. There are some areas where some patients are slightly sicker than the rest of the lot. So if that particular group is been monitored by a remote monitoring, and the integrated value comes directly to the smartphones of the rapid response team, probably the intervention is going to be fast and outcome is going to be good. And moreover, the nurses are watching. If you have a central nursing board station which helps us to get the values, so that an external eye also is there to help the bedside nurse. These are the benefit if you have a remote patient monitoring in our hospital. And this is the project which we did. I would like to share the experience of first we monitored what is happening in the emergency department. The challenges I mentioned there. Most of the patients belong to 3 groups. Red, they will be attended and they will be taken care of. No confusion in that. Green, they are stable patients. They will go to the ER waiting area or ER area where they will be addressed accordingly. The orange or the priority 2 is a group where they are in the middle of both. So that patients can go into a bad state. They can deteriorate as per our terms and cause trouble. And the monitoring in a busy ER where they have 100 things to do is not going to be very good. So we kept this monitor for 3 days, 15 patients we did. And the status monitor, what we have shown here, it captured the data, and it has done 2 things. It once goes to the central nursing board, where we have in our ER, one doctor or no nurse is sitting in front of the computer always, because their responsibility is to enter the patient details, enter investigations, and call consultants if anything is there. So they get the first alarm if any of these parameters are getting bad. So then external person is looking into it. And second thing, one of the ER consultant doctor on call, his phone is also get a bleep. So what you have shown with the limited number of patients is that the orange patients who has been in the borderline of getting bad, or they'll remain stable, but that getting worse is been picked up much earlier if you integrate all this thing, including a remote patient monitoring, which comes to the doctor's hands without any delay. Similarly, in ICU, we utilized it in a step-down ICU. This was during a COVID time. COVID time, we are managing 2 ICU. One is a intensive care unit, which is sick patients. The step-down ICU is a group which has got not very sick patients. But you can't keep one nurse in one area, one patient as per the ICU. So we kept this monitored, and overall, we asked me what is the personal experience is that the vital parameters, especially the oxygen saturation, when it gets to an alarming low level, the alarms what came to the clinician's mobile and the central dashboard alerted the healthcare workers, so that sudden deterioration is picked up early and acted as and when required. How does it work? This is a picture representation of a step-down ICU. It is not as sick as an ICU, where you have 3 beds covered by whatever curtains, whatever you call it as. The monitor gets the data, goes to the cloud, and 2 areas what we experience is that one is a central monitoring area, second thing is the clinician's phone, which gets the alert, so that early pickup can happen. And lot of technologies are available. It's all purely your decision how comfortable you are. But as per my thing, if it's a single device monitor, and status monitor has been approved for an FDA for accuracy, and it is utilized as web app. Of course, mobile app is there, and data integration is another benefit of that. And all our use cases, the early phase, the pilot 1 trial showed definitely a benefit in getting a good patient care. I would like to share a few thoughts. Sorry for that. a few thoughts when you talk about small hospitals, how does it enable? Now every hospital, small or big, there are multiple ICUs have been happening everywhere. Single unit concept of 30 beds or 20 beds is going out. Okay, thanks. Now there is a multiple ICUs. When I presented this thing in one of the conferences, the CMC Vellore, they have a new building, new hospital is built up right now. The doctors, ICU doctors there came to me, sorry for that, they told me about their problem. We face problems because expansion happens in every hospital. So when there are multiple ICUs in multiple level, it is not humanly possible for one team or one or two persons to monitor everywhere. So what about you having this remote monitoring systems in every place, so that the alarm systems will helps you, or the monitors will help you in picking up deterioration. Something definitely needs to be thought about. And I put a term called as augment the referral system. When you talk about smaller hospitals, if government or private setup, you don't need to refer everybody to a major center. This has got a lot of implications. The cost is one factor. So if the remote patient monitoring help, as in, suppose for example, if a taluk hospital needs to refer to a city or a government city hospital or a district hospital, if the monitoring parameters is tracked live by the referral hospital, probably they can guide them and telling that, of course, we can give some time, and it is a confidence booster for both the patients and for the doctors in the taluk center. The third point I would like to initiate a discussion here is that I put a term called as referral back system. When we talk about referral back, we are a referral hospital. We get a lot of patients referred from the periphery, which we call it as the secondary care. But I believe Kerala, everybody is a good setup. They all can manage an ICU critically ill patient. So when I get a referral, what about me referring back to them after the initial part, patient is getting better, so that they are in their own hometown, their own place, and with the help of remote patient monitoring, my team is tracking the patient's clinical situations and the patient's labs and monitors everything, so that there's a moral boosting and a confidence boosting thing for the person who have referred to me and the patient family who knows that we are also in the picture. So this is another thought process which technology needs to be taken. And the last part is a home-based ICU care. Why I'm saying is that I've always believed that patients who are sick will be much more recovery can happen if the family's presence and this familiar environment is there. Home-based ICU care is gaining acceptance a lot. Lot of technology and companies have come up right now. Remote patient monitoring. I personally believe that if I can get a chance of a patient being in the hospital and I get technology to help me, home-based ICU care is going to be a reality, and that is going to make a huge boost in the coming years. My dear friends, thank you for your patient listening. That is what I have to tell you. Any questions, I'll be happy to take.
Thank you, Dr. JAICOB. Thank you very much for very crisp. And any questions from the audience for Dr. JAICOB? Because he will be leaving shortly. I think it's a very relevant topic, Dr. JAICOB, and because during COVID over the last 2.5 years, there were a lot of patients being managed at home. And there are a lot of scarcity of doctors, nurses, so there were a lot of patients being managed. And I think it's already in. And I know as we accredit home care providers, a couple of them are setting ICUs at homes and then sitting. And we had a presentation yesterday from Cloud Physician. Yes, so they're also managing critical care patients in ICUs. So I think technology is already existing, the practice as well existing. And it's a good way of basically to fill the gap of resources. Otherwise, how long we keep saying we don't have enough nurse, we don't have enough doctor. You don't have. You can't create overnight, so at least you have some innovative ideas and products and processes built into systems so that you can fill that gap more efficiently and more effectively. So I think this RPM, usually we use the RPMs is round per minutes, right? So now we are using remote patient monitoring. So things are changing. Of course, people should not get confused. But things are changed, and personally I have seen that how effectively this has been put into place, where patient is receiving much better care. And I think you all work in hospital, not me, but it's a challenge, and I think I was completely in agreement when you say you step down from ICU to HDU or towards it, in fact, the care level goes down with the mindset that you are okay now, you don't need much. But that is good when you are really recovering on this way. But if you are recovering and then, you might miss those critical alerts, and that would make life difficult for the patient. Anyone? Any questions? I was trying to think some questions for him. Very interesting. But I think obviously because it's a new topic as well, so I would take it that everyone is trying to think, and as well as it was very clear and crisp presentation, so they don't have a question. So thank you very much, Dr. Zaga, for your wonderful opening. And we would have wished that you could have stayed, but yeah, so anyway, you are excused from the audience side, and I think we would like to present our appreciations for your presence.